All right, Dr. Jones, we're at it again.
At it again, my friend.
Hey, how was your week in clinic?
It was good. We were busy as always, but had some really interesting cases, both surgical and clinic. So it was fun. How
So
about you?
yeah, the same thing. I did Mo's just one day this week, and then had a lot of medical patients this week. What would you say is the most interesting case you did this week, surgical or medical?
Well, we had some on the clinic side. I had an interesting interstitial granulomatous dermatitis case. And so I was kind of reviewing her med list, thinking maybe it was like a drug eruption. And one of the most common medications to be associated with this is a tricyclic antidepressant, and she was on amitriptyline. So, and she'd been on it for years, and based on kind of a review of the literature, it can take years for this type of rash to develop. Really wasn't bothering her. She was happy on her medication, so I just said, let's just see how it plays out. We don't need to change it at this point. So I don't know. That was kind of interesting. On the surgery side, I had a kind of a fun advancement flap on the nasal tip that we did, just kind of a smaller little defect, and it was kind of fun to close that. So, how about
Yeah.
you?
I saw a patient back this week who I did. He was sent to me for a pretty large skin cancer on the kind of left cheek, a little bit in front of the jawline, and his primary care doctor had picked that up, and it was bigger than the size of a quarter, so it was pretty easy to see. But then when he came in for his consultation, a few months ago, he had another, what to me was an obvious basal cell, about a centimeter and a half away. And so when, I could see that, I don't, expect his primary care doctor to pick up every, little tiny basal cell. And so when we did his Mohs, I was like, well, I have to treat both of these at the same time, because I can't, remove one skin cancer and then close him up and then tell him, months later he's got another skin cancer. So it was like, we got to do them both at the same time. And so it ended up being that both of these were pretty large skin cancers. The one that I thought was small was turned out to be a lot bigger. It went, multiple stages. And so he's got these two big defects. And we closed it in this kind of, double rotation advancement flap. I don't even know what you would call it, because I was just kind of throwing things together just wherever his skin tension lines would go. And saw him back this week, and it just looked beautiful, and he's
Nice.
going through a lot of other health issues, and just speaks to like how vascular the face is and how well you can heal when you just put things together and you take really good care of it from a post-operative wound care type of thing. So there's a lot of misconceptions on that too. Like, what do you tell patients to do for wound care after you close them up for skin cancer surgery?
It's kind of funny. I kind of like a simple method, and I think that works for our patient population here. I basically go some type of moisturizer. I really prefer Vaseline, and then I like keeping a wound occluded. I think there's pretty good data that supports, an occlusive dressing is going to cause a hypoxic environment, and that gives good signaling for your keratinocytes to start to reepithelialize over the scar. And then keeping the wound bed moist also promotes that. The flip side to that is people don't like doing that for long periods of time. And so, and then they'll sometimes, and understandably so, think the wound's infected
Mm-hmm.
because it's more moist, and you see some of that granulation tissue and some of the, yellowish exudate that can be tricky if you're not used to it. So there's a lot of education for patients to do it that way. Some patients don't care. They just want to, they want to let it dry out, let it scab, and just not worry about it. And so a lot of people end up just doing that despite what I tell them.
Yeah. I was going to say, like, you probably have a lot of the old farmers that you take care of, and they're like, they've done it the same way for so long. They just think like, you got to let that scab form. You got to let it
Yep.
dry out. And they're just going to be just as active. And so they're not going to take the time to, keep putting Band-Aids on and Vaseline. And so have you
Yeah.
seen people come back with allergic reactions from Neosporin? I know derms talk about it all the time, but have you seen it?
We actually do. I don't know everybody. I mean, Neosporin, that company has advertised and marketed very well, because I think every person in America has a tube of that. Everybody uses it, but we have seen a couple. Definitely not a ton like you would think going through derm training where we talk about it all the time. So we do try to avoid Neosporin. We use bacitracin for some wounds, and I see reactions to that too. So, but then we also see reactions to adhesives. I mean, people react to stuff. So
Yeah, definitely. There's, it's more that like you can save money by using Vaseline. You're definitely decreasing the risk of postoperative like irritation, allergic reactions. And in reality, when you did a clean surgery, the infection rates are the same, whether you're using Neosporin or whether you're using Vaseline. So there's not a lot of value add in using the antibiotic ointments.
I know.
I use like gentamicin if I work on the ear. I often prescribe that for somebody because it covers some of those unique infections on the ear. But just different approaches. But derms, kind of are pretty dogmatic against Neosporin. So
right. There's been some pretty good studies that have come out about not using sterile gloves for cutaneous surgery. What are your thoughts about that?
Yeah, I actually did a commentary with a Mohs surgeon out of the Mayo Clinic named Jerry Brewer, and he had been invited to do a commentary on a paper that came out comparing infection rates for wound infection rates with sterile gloves or with clean gloves. And that's just, the box of gloves that you see in every doctor's office. And the data would suggest that the infection rates are essentially the same, whether you're using clean technique or sterile technique. And that's one thing that I get a lot of comments on in videos from time to time is that somebody will see me doing surgery, whether it's a skin graft or a flap, and they're like, why are you not using sterile gloves? Like that, you're violating the standard of care. And I'm like, no, actually, there's been a lot of data to support that this is, very safe, that the infection rates are very low, and it saves the healthcare system money, because opening up one pack of sterile gloves is probably, I don't know exactly what it is, $3 to $5 per pair of gloves, I would think. And, you're talking about maybe 10 cents per glove for clean gloves. And so whether it's a large hospital system or whether, even more importantly, so if you're a privately owned clinic, every place you have the opportunity to save money, it's not just money in my pocket, but it gives me the ability to then make decisions for patients that are not in my financial best interest.
Right.
I don't feel the need to nickel and dime a patient on everything, because it's like, if I can save a little money here or there, I'm a lot more comfortable giving courtesy visits for follow-ups and things like that.
For sure.
Just, being able to do the right thing for patients. So I don't use sterile gloves except in very rare circumstances. How about you?
That would be my preference. When I, came here to this practice, my partner, still uses sterile gloves. And so we kind of kept that up. Also, our clean gloves are really slippery. And so I don't often like to operate on those. So I'll do the most stages with clean gloves. And then when I'm ready for the closure, I still use the sterile gloves. Eventually, I do want to change that. So really right now, it's more, my partner's preference and the fact that our clean gloves aren't the best as far as like grip.
Yeah.
And part of that's because of COVID and some of the supply chain issues. We just haven't been able to find some better gloves, but we're actually getting another supplier on board. So I'm hoping that'll change.
Yeah.
But yeah, it's interesting because we've had that data for a while, and where I trained at the university, all of the Mohs surgeons that I worked with are like, yeah, we don't need to use sterile gloves, but then they did.
Yeah.
So it's really hard to change that because you know what the data says, but then your anecdotal bias kicks in, and anytime you see that one patient come back that does have an infection, it scares you, and you're like, all right, well, what else can I do to not to reduce this risk?
Yeah.
So it's kind of interesting.
Yeah, and none of those academic surgeons were paying for those gloves either.
Right, exactly.
So. But yeah, it's interesting that there's different approaches on that. But I think it's important for people watching or listening to know that it's actually been studied, that there's data behind it, and that you're in very good, safe hands if your cutaneous skin surgeon isn't using sterile gloves for every step of a procedure. If you're having abdominal surgery where they're opening you up, yeah, you need sterile gloves obviously for that. It's a whole different level of risk. But you're good in the office setting. For cutaneous surgery. So
for sure.
This week was Melanoma Monday, and May is Skin Cancer Awareness Month. And we talked a little bit earlier about seeing if you can give like an update for people on like what are the melanoma statistics nowadays? Why do dermatologists make a big deal about melanoma every May?
Well, melanoma, as we know, is one of the more rare types of skin cancer, but it's also the most deadly. And so it's a big deal. When people get melanoma, it's a big deal, and we take it very seriously. And so, I'm sure your clinic's the same. Once we get a diagnosis of a melanoma, we move very fast. We're really trying to get a wide local excision within the week. And unfortunately, the statistics really are showing us that the incidence rate of melanoma is increasing as we go along. So I pulled up some statistics from the American Cancer Society. There's an estimate of about almost 100,000 new cases in 2022, and about 7,600 deaths from melanoma estimated for 2022. So that's about almost 23 cases per 100,000 people of melanoma, which is kind of scary. And so, then we think about our risk factors, and I think that's where, Melanoma Monday and, some of these events play into awareness, is to think about, okay, well, how can I reduce my risk of melanoma? Mm-hmm. We know it's deadly. We want to do everything we can to prevent it. So what can we do? Well, sun protection. Okay, that's going to be a big one because sun exposure is a huge risk for melanoma. Sun tanning, tanning beds, big deal. How can we avoid that? Age is another big risk factor. So I think the highest incidence is after the age of 65 for melanoma diagnosis, although melanoma also occurs in a younger population. We don't really see a lot of basal cell or squamous cell in the younger population, with exception, but melanoma is one we do, even under 30, even, I've seen several patients in their early 20s that have a diagnosis of melanoma, usually people who are doing a lot of tanning. So it's something everyone has to think about.
Yeah, totally. We didn't cover this on the last time that we visited, but you lived in Australia for a little while, and they have very high rates of skin cancer over there. The sun exposure is very intense. Do you think that gives you a unique perspective on the approach to diagnosis and treatment of melanoma?
I don't know if that does necessarily, just because I wasn't doing anything medically related while I was in Australia, and so. I wish I had some medical colleagues out there from Australia that could give me better insight, but unfortunately, no. I would say, my training in Utah may give me some perspective, because Utah has one of the highest rates of melanoma population. In fact, this website is actually pretty interesting. We can even break it down by state. So I was kind of looking at Idaho and Washington, where we're both at currently. Estimated new cases in Idaho, 940 estimated for 2022. Washington would be 2,500, and Utah, 1,600. So, yeah, kind of interesting.
Yeah. I would just share kind of an anecdotal thing that we experienced this week. I have a patient who came to me for the first time, and they had on skin exam a pretty large, ugly looking mole on their lower back. And so, immediately I was like, we got to biopsy this. This looks really bad. I looked at it under dermoscopy, and it was very, very, like I was willing to bet the farm that this was going to be a melanoma. And unfortunately, it turned out to be a melanoma. And it was, over 2.5 millimeters thick, which to dermatologists, we know that's a really dangerous territory. And so immediately we got them into general surgery. They had a wide local excision, a sentinel lymph node biopsy, and then we ran this test from Castle Biosciences, which kind of gives you a genetic marker on the melanoma. It's not necessarily part of the standard of care yet, but I think it will be in the future, like we use a lot of genetics for breast cancer. And it was a bad result on that test. It was, kind of the highest risk type of melanoma. And the patient came back, for regular skin exams. They were very good on follow-up, never finding anything. And it's been over a year. And then on a recent exam, because, if you've had melanoma, your dermatologist unless your melanoma was maybe like 15, 20 years ago, if you have a recent history of melanoma, your dermatologist should be palpating lymph nodes on exam. And so on palpating,
Absolutely.
the neck, the armpits, the cervical, feeling the liver, feeling the spleen, and then the inguinal lymph nodes, I was feeling around her pelvis, and there was a nodule kind of sitting just above the pelvic bone. And I was like, this wasn't there before. And the
Mm.
patient's like, well, I bumped, the countertop, and I don't think it's anything. I was like, no, we're getting you back to the surgeon. And unfortunately, it was melanoma once
Oh,
more.
man.
And it's heartbreaking to see that happen, because when it's caught late, when melanoma is caught at that 2.5 millimeter stage, it can be real dangerous. And then, this patient needs chemotherapy, radiation, all these other things. And I just had to follow up with the general surgeon, and he informed me that he had to spend over 3 hours on the phone with her insurance company fighting to get a PET scan for a patient like a nodule of melanoma in their pelvis.
Unbelievable.
Yeah, and it's just, so we have patients' best interest at heart, but there's not necessarily your insurance company or just the way the healthcare system works. There can be hiccups. So it just speaks to me about the importance of early screening, and you got to get in there and get these diagnosed ASAP. And that's why regular screening with a board certified dermatologist is important.
It's super important. I tell all my patients all the time, I would rather if you see something that's changing on your skin rapidly, that's one of my biggest data points, is if something's changing rapidly over a period of, 1 to 3 months, either size, shape, or color, that's something I want you calling me about. I don't want you waiting till your next appointment. The quicker we can catch these, the more life-saving that's going to be. And I would rather people come in and I say, oh, that's just a seborrheic keratosis, no big deal, right?
Absolutely.
Like, that's totally fine. We have the training to be able to see something and know what it is. If there's any question, we're going to biopsy, or if we know it's cancer, obviously it'll get a biopsy. But I don't expect other people to know that. But if they can know that something's changing, something doesn't look right to them, come on in.
Yeah, absolutely. So I want to switch gears a little bit. This week we had, an event called the Met Gala in, pop culture. And the Met Gala is this like big event that happens in New York, and all the celebrities show up and they walk the red carpet. And I have a little fun each year doing like a red carpet review where I talk about the celebrities' outfits, but only from a dermatology perspective, because I don't know anything about
Nice.
fashion. But there was an interesting red carpet walk this year by a lady named Cara Delevingne. I think I'm saying her last name right. I don't know who she is or what she's been in. I don't know if you're familiar with her.
No.
But
A good actress, I'm sure.
I'm sure, very talented. And we'll, put this on the screen, but, she was wearing this really nice Dior suit, and then she took the suit jacket off, and she was really not clothed much under that. She had pasties on and some gold chains, and she had gold paint on her body. But one thing she didn't do is she didn't paint her elbows, and she was prominently showing off that she has psoriasis. And, I didn't know about this diagnosis beforehand. But you can, clearly see pretty large plaques of psoriasis on each of her elbows when you look at that. And so I just thought that was interesting and wanted to pick your brain about that. Like, we know we have tons of great ways to treat psoriasis nowadays. And whether you're, on, a low income bracket or a high income bracket, most of these medicines have really good access programs where even patients who are, below the poverty threshold are getting them for like $0 or maybe $5 a month. So I was, it kind of perplexed me if she has decided not to undergo treatment, or if she has decided not to go through biologic treatment. And I just thought we, might talk about that a little bit.
Yeah, I've seen patients that have an issue with some of the newer biologic medications as well. And I always have this conversation with them, because I get that every medication has side effects, right? And so there's always benefits and risks to any medical decision you make, any procedure, any medication. So I get that. The issue is that psoriasis, uncontrolled psoriasis, also has risks to it. It's not just cosmetic. I mean, it's a chronic inflammatory skin condition, but it's also associated with other inflammatory problems like cardiovascular disease, depression, stress, weight, obesity. I mean, there's all kinds of associations with uncontrolled psoriasis. And so why not want to reduce, your risk for those things when we have so many options available that are safe?
Mm-hmm.
Okay, they have side effects and things to be aware of, but those are really rare things that can happen. So why not use some of the tools that we have now to treat psoriasis and treat it well? That's always, it does perplex me a little bit when people decide not to pursue treatment. And I think it's probably because they don't fully understand, that type of decision and the outcomes that could have.
Yeah, I think that's a good point to bring up, that psoriasis, although it looks like a skin disease, is a whole body systemic inflammatory disease, and it can affect your heart, your blood vessels, increased risk for diabetes, heart attack, stroke. So if somebody out there is watching this, I think it's great that she feels confident in her skin.
Absolutely.
Because psoriasis is not contagious. It's a very common disorder. A lot of people have it, and you may not know it.
I think it's estimated at like 3% of the population or more have psoriasis or will have psoriasis.
Yeah. So, it's important to be comfortable in your own skin, but there are potential complications that can happen from not appropriately treating something, even if it just looks like a skin disease.
Absolutely.
So,
yeah. And even just the most common association of psoriatic arthritis, right? I think it's about a third of patients with plaque psoriasis are going to go on to potentially have joint involvement.
mm-hmm.
And so, sometimes it's harder. Obviously, it's harder to see, but that damage is lasting in your joints. And so these biologic medications treat not just the skin, but they're also treating joint disease.
Yeah.
So, it's just another big reason to treat this effectively.
Yep, absolutely. All right, so as we kind of wrap things up here, I thought it'd be fun to do kind of a segment, because on social media, one thing that's always amused me is some of the DMs that I get. So I get some pretty funny direct messages, and I do my best to reply to everybody who's asking a legitimate question. But every once in a while, you just get something that's really entertaining that comes in. So I've got a business proposal for you, Dr. Jones, because this was given to me, and I think I'm going to pass on it. So we've got 3 different messages here. I'm going to read them, and I want your reaction to see if this is a business opportunity you'll jump at. and we'll put this up on the screen. So, hello. Regarding scabies, I would like to introduce a product to you. Some time ago, I got this disease through my pet, and I went to thousands of hospitals and doctors and used all of the drugs for this disease, but the situation only got worse until my wife discovered a formula herself. And when that formula, we used it, in just 2 days, the whole disease disappeared and I was cured. Okay,
Whoa.
So we'll pause there. Initial reactions.
Did she come up with a new strain of ivermectin? I mean, sounds legit.
It sounds legit. First off, good on this person for having the means to visit thousands of hospitals and doctors. I'm fully on board so far. I totally believe this story. And then curing scabies in just 2 days. That's also quite remarkable.
It's amazing. I mean, that's a miracle in a bottle.
Yeah, it really is. You treat scabies and patients are probably still going to be itchy for up to a month, but this guy was cured in 2 days. So it keeps going. And since then, more than 200 people who came to us with this disease had gone to many doctors and hospitals and even been involved in this disease for 6 years. When they used our formula, were cured in less than 3 full days, even themselves. They were surprised. Now
so they've opened up shop already.
They have. They are entrepreneurial. They have discovered the fountain of anti-scabetic treatments.
It's a subspecialty.
Now my wife and I have decided to present the formula we have obtained to someone who has the ability to register it and can offer it to the whole world and people so that everyone can be cured. We decided to get some money for the miracle formula we have and sell it to someone who has the power to register it in his own name and introduce it to the world medical system in the form of medicine. We have 2 decisions in the form of medicine, of course.
In the form of medicine.
I'm not sure.
So it was a spell before, but now it's going to be medicine.
I am unclear on what form it was prior to their idea that it would be a medicine. So we have 2 decisions. One is for an investor to support us in the global registration and presentation of this drug. And the other is that someone who has the power and can assign this formula to himself buys this complete formula from us and registers this drug and presents it to the world so that everyone can get rid of this disease. Because none of the drugs in the world can cure this disease, and this is the only way out. We even had clients from several European countries who asked us for medicine and were treated. The end.
Well, they've really hit it out of the park, I'd say. Where do I sign?
Where do I sign? I have not replied to this DM. I would be very curious to know what they're selling this miracle formula for, because it's obviously an easy process once you have the formula to just register the drug to the whole world.
Yeah. I mean, that's how all drugs go through the FDA. I mean, you basically just send an email.
You just send not even an email. Like, this is sliding into the DMs on Instagram.
Okay.
So for anybody out there watching or listening, if you have been to thousands of doctors and hospitals and you're suffering from scabies from your dog for 6 years, I'm happy to put you in touch with this individual to obtain the cure.
It's not a medicine yet.
It's not a medicine yet, but it will be.
But it will be.
Okay. Well, Dr. Jones, always a blast.
Absolutely, my friend.
So,
really fun.
We'll keep refining this. I think we're having lots of fun and do kind of some of these fun segments as we go forward. And for anybody watching or listening, we welcome your feedback. Send us DMs at 208SkinDoc or at DermXMD. And we're going to keep getting content out there for you guys, answering your questions, covering news in dermatology. And we can't wait to see you back next time.
Absolutely. Take care.
Bye.